Hello and welcome to CLP's webcast, The Essential Role of Hormone Testing in the Management of Infertility and Anovulation, sponsored by Toso Bioscience, Inc. I'm Chris Wolski, CLP's Director of Business Intelligence, and I'll be the moderator for today's presentation. Now, at the conclusion of today's event, we will have a short Q&A with the webinar's presenter, Dr. Giuliana Puccini. Please, at any time, feel free to submit a question via the Q&A box on your right there on your screen. And those questions that are answered will be addressed directly by Dr. Puccini and the TOSO team after the conclusion of the webinar. Today's webcast is being recorded, and you will receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on the GoToWebinar platform for the next 3 months. Today's speaker brings over 30 years of experience in medical practice, with 20 years dedicated to obstetrics and gynecology. Dr. Puccini currently serves as a university professor at Andes University in Bogota, Colombia, and as a GYN OB physician at the Foundation of Santa Fe de Bogota. In addition, she has more than 10 years experience in private practice with associates in fertility and human reproduction, Inc. And she has also authored numerous research papers and national publications. So without further delay, it's my great pleasure to hand the proceedings off to Dr. Puccini. So take it away.
Thank you very much, Chris. So let's start. So here today we are going to review some aspects of infertility, how to study infertility couples, and the clinic issues that you should know. Because infertility is a disease of the male or female reproductive system defined by the failure to achieve a pregnancy after 12 months or more of regular and protected sexual intercourse. If you review the World Health Organization statistics, around 17.5% of adult population is going to ask for help in this issue. And it's a disease that doesn't make differences between high, middle, and low income countries. In the United States, 12.7% of reproductive age women seek infertility treatment, and in 1 in 8 women receive infertility services. The ovulatory disorders account for approximately 25% of these cases, and 70% of these 25 are going to be polycystic ovary syndrome. Infertility can also be a consequence of underlying chronic diseases, and 15% of the infertile couples have unexplained infertility too. If we are going to analyze the question by sex, 50% of the female factor, 30% are male factor, and both female and male combined are going to be responsible for the 20% of the causes of infertility. As you can see in the squares at the left, different causes and problems, either female or either the male in the couple. So when you are going to make a medical history of these people, the first question that you have to do is, how old are you? Who are you? How old are you? And why are you coming to this consultation? When? Because it's important for us to see if the woman has hormonal disorders, previous surgeries, smoking, alcohol, illegal drug use. On the gynecology history accounts, because some of them are completely menstrual irregularities all in the life, previous pregnancy, dysmenorrhea, dyspareunia, sexual transmitted diseases, or the chronic use of contraceptives or non-steroidal anti-inflammatory drugs. And the request at the end is going to show you that we need a lot of paraclinical tests according to the diagnostic impression and to offer a treatment. The reason of the age, that is the most important question, is because if she is less than 35 years, she can just wait and try making her intercourse 2 to 3 times per week and wait for a year to see what happens. If she's between 35 to 39 years, she has to consult again, no, the first time, 6 months trying, and she cannot, she may go to the doctor. But she is more than 40 years old, she cannot wait because there is no time. So it's very important to let the women know more in these times that everybody has to, a lot of jobs and work and career challenges. So keep avoiding pregnancy until the age that is not going to be easy to do it. This is called ovarian aging. So how to study infertile couples? You just see that the male factor is easy, just an abnormal spermogram gives you a lot of information. Uterine difficulties with the cavity, polyps or uterine malformations. In the tubal, if the tubal it has hydrosalpinx or endometriosis, but the center or one of the most important causes is the ovaries, because they are not only just seen in images, but they have a lot of hormones implicating a good ovulation to find the pregnancy. And there is the remaining 15% that has unexplained infertility. So we are going to focus on ovarian factor. And those are the tests that you have to perform when you have a complete study of the couple. But as I told you before, we are going to find interesting here in ovarian cycle, doing the hormonal test you see there, and the transvaginal ultrasound, because it's going to talk us about the ovarian reserve. So for that issue, we need to know the normal menstrual cycle. And the normal menstrual cycle has all this hormone that you see here, but important for us are anterior pituitary hormones, where has the FSH or follicle stimulating hormone that has to be measured during the days 2 to 4 of the menstrual cycle and serves as a reliable indicator of ovarian reserve. And the normal values should be less than 10 international units per milliliter, accompanied by basal estradiol that has to be, it should be less than 60 picograms per milliliter. The other hormone is the luteinizing hormone, or LH. Its values can be between 1.7 and 13.3 international units per milliliter, and it is doubled the FSH. It is doubled by the FSH, excuse me, when they are measured in the early follicular phase. So if you want to make a diagnosis of an ovulating woman, you should take the measure on day 3, for example, of FSH and LH, and the FSH value has to be doubled in front of the LH, and this way you can tell that the woman is making ovulation cycles. During the mid-cycle, the LH reaches the values between 4.1 and 68.7 according to the time of the trigger that has to suffer to make the rupture of the cyst. And it reaches these values and are crucial to triggering ovulation. Other way, the ovulation doesn't come. The ovarian hormones then making the answer to the pituitary hormones, then the ovary start producing estradiol at the beginning of the phase, the follicular phase. The threshold values in early follicular settings are 21.8 to 83.7 picograms per milliliter, which in conjunction with normal basal FSH levels signify a favorable prognosis for ovarian response to stimulation. Progesterone is measured in plasma during the mid-luteal phase. So we have estradiol here, then comes the triggering of ovulation, and then we have the elevation of progesterone that is preparing the endometrium to receive the embryo. In the mid-luteal phase, to determine whether the cycle has been ovulatory, when progesterone levels are more than 10 nanograms per milliliter on days 20 to 22 of the cycle. It only provides, it's very important for you to know that it only provides information about the cycle in which it is measured, and it cannot be used to predict future cycles. It's like my boss says here is the picture of the day. And in this day, you have your measures, and the other cycle can be completely different. So you have to perform this test each time that you are going to make some treatment to the patient. Anti-Müllerian hormone in females is secreted from the ovary pre-birth, regulating ovarian follicle growth, and it's maintaining stable levels from age 2 years old until the adulthood. It is progressive decline and is a sign of decreased ovarian reserve, reaching almost undetectable levels 5 years before the menopause. Menopause is considered when you have one complete year without any menses. Those patients with high levels, more than 3 nanograms per milliliter, are more likely to present hyperstimulation ovarian syndrome when you it makes a controlled ovarian stimulation. And the other tools that we have to know how is the ovarian reserve is the ultrasound, transvaginal ultrasound, to make an antral follicular count. This antral follicular count should be performed in days 2 to 5, even when the woman is menstruating still, because we can see all the possibilities that she has, or the follicles that she has that can be stimulated by the medication, in the case that you are going to have an in vitro stimulation, to make an in vitro treatment. The volume of both ovaries are measured, and the average is one of the clues. All follicles between 2 to 9 millimeters are measured too. Residual cysts from the previous cycle are reported, and always have to check the endometrial cavity. This is a 3D ultrasound reproduction or reconstruction to see the cavity, because you can make all the steps, have a good ovulation, collect all the ovocytes, and when you are going to put inside the embryo, the polyps or myomas inside the cavity are going to make all the damage, and you are not going to find the pregnancy that you are looking for. So always check the endometrial cavity, and these results in conjunctions with all the hormones are analyzed. This is a scan ultrasound in the modern machines that we have. We can make reconstructions in 3D ultrasound. This is called TUI, that is tomographic ultrasound imaging. You can cut the ovary in different planes and count the follicles. This is a case of polycystic ovary syndrome. And you know the amount of follicles that has this woman. We consider more than 20, and one of the ovaries is is the shape of these ovaries. And in the new machines, again, they can just draw them, draw the follicles just in a click, and show you what is the amount, so it's easier. But it is special cases of a polycystic ovary syndrome, just to put it as an example. We make an investigation paper that presented in 2018. This is from our Asociados en Reproducción Humana here in Colombia, that we are questioning what are the variables to establish an efficient ovarian reserve profile. Here is the description of the variables that we made. We took in account age, body mass index, FSH, LH, the relation between them, estradiol, anti-Müllerian hormone, volume of the ovaries, follicular count, and the ovarian, and the results gave us an ovarian profile reserve. What did we find? Definitely the ovarian, the anti-Müllerian hormone, the follicular count, the FSH, and the LH alone, not in relation, are the more, has the P, a significant P in a 95% interval confidence ratio to analyze that the woman has poor or good prognosis to carrying a baby, and the other variables were just were not significant, statistically significant. So we keep performing this test to study our patients. If you are going to the classification of anovulation according to the World Health Organization, we have different groups according to the results. Group 1 is called hypogonadotropic hypogonadism and is characterized because all the hormones are down. FSH, LH, and estradiol are very low, and the causes, you can read it there, but are basically you have to look with multidisciplinary people, equipment of doctors, because you can find primary pituitary tumors, anorexia. It happens very frequently in high performance athletes. This is the reason, the importance to know the woman that you have in front. She has syndrome, sarcoidosis. The other thing, the other group is normal gonadotropic normogonadism. And in this case, you are going to be normal in both results, but she only cannot get pregnant. You have to look for polycystic ovary syndrome, congenital adrenal hyperplasia, chronic use of non-steroidal anti-inflammatory drugs. And this is very common in people that has dysmenorrhea since the first menstruations. And she takes a ibuprofen or diclofenac or each time that they are getting the menses. And the group 3 is hypergonadotropic hypogonadism, where you have the estradiol down, but you have very high levels of FSH and LH. And these results over 20 or 30, you are going to predict premature ovarian failure, almost complete depletion of the follicles before 40 years old, that is early for a woman, or is a woman that has been with radiotherapy or chemotherapy because of cancer or previous ovarian surgeries. They're important again of the clinical history. When you go to the treatment, you have a lot of treatments, and just point there's medications as an example, but you can use clomiphene, aromatase inhibitors, gonadotropins, or combinations of one of them or two of them. But the important here is that never you can make a cycle to stimulate the ovaries without transvaginal ultrasound, because you can have cysts, previous cysts that can be broken, and you are going to make a damage in the ovaries. At the beginning, you should have, as I told you before, FSH over LH to see, or just independent, to see what are you going to expect. And in the follicular phase, you start making the measure of estradiol according to the amount of follicles. In the middle, you can use gonadotropin, human chorionic gonadotropin, that is going to mimic the LH, because we are talking here about an artificial cycle, and they both share the same, almost the same shape. So you can use this to trigger the ovulation. And when you have the ovulation at days 20 to 22, you are going to take the measure of serum progesterone to see if the luteal phase is going out. I have to see this slide only to let you know that polycystic ovary syndrome is the most common endocrinopathy affecting women of reproductive age, with repercussions through life from adolescence to menopause. And depending the diagnostic criteria, this disorder affects between 6% to 20% of reproductive aged women. And we have a lot of Rotterdam criteria and a lot of things that we can use to organize this, to make the diagnosis. This diagnosis is very common, but at the same time is over-diagnosing in most countries. But we can observe 70 to 33% of healthy adult women and up to 40% in healthy adolescents. So you have to be careful not using all ultrasound, but using all the hormone measures too, and the contextualized. I don't know if it is well done, well said, but you have to make all the history of the patient and know the medications and how is the cycles and what is she doing to avoid pregnancy, because in an inadequate protocol in these patients can cause hyperstimulation ovarian syndrome. So if you are not expert to give this kind of medications, you should avoid to do it because you can produce a serious damage. Or other diseases that can lead you to have anovulation syndromes are thyroid function, because the thyroid is very important in the infertility square. The hypothyroidism in women has been linked to oligomenorrheas. The overactive thyroid, in the case of thyrotoxicosis or hyperthyroidism, is associated with hypomenorrhea and polymenorrhea. And low levels of thyroid hormone can interfere with ovulation, causes anovulatory cycles. So it's one of the hormones that we have into our tools to study infertility women, and men too, because the men has consequences too. And the hyperprolactinemia and infertility, when you have high levels of prolactin, interfere with the normal production of estrogen and progesterone, leading to anovulation and irregular or missed menstrual periods. And some women may have elevated prolactin without any symptoms, and this is the problem. When the woman comes to you to say, I cannot get pregnant, never forget to measure that. There are sad histories of women that never been measured to prolactin, and that was the problem. And she would find a pregnancy if the doctor just measured and gives the adequate treatment. The treatment is just cabergoline or bromocriptine, or in very few cases surgery when are tumors more than 10 millimeters. So my conclusion here is that understanding the magnitude of infertility is critical for developing appropriate interventions for monitoring access to quality fertility care. It is very important for the clinician to have reliable and rapid hormonal results, because as you see, this is dynamic. So you have the patient coming here to the appointment, and you just need to know in what time of the cycle are you, or what is the answer to your medication. So you need rapid hormonal results between 1 to 3 hours, because they are the basis for both diagnosis and treatment monitoring in patients who require assisted fertilization therapy. Thank you very much.
All right. Well, thank you, Dr. Puccini, for your presentation. It was very interesting. And we did have some questions come in. So with the time left, let's answer some of those. And if for the audience, if you haven't already, please input your questions in the Q&A chat box. If we don't get to those during the presentation or during the Q&A period, those will be answered in writing after the fact. So let's get started here. All right. So, Dr. Puccini, how often should hormone levels be monitored in patients undergoing fertility treatment?
Okay, so as I mentioned in the lecture, at the time of diagnosis, we need to make FSH, LH, estradiol, and multimillennial hormone at the beginning of the cycle. It's very important for you to go to home with the idea that it's between 2 and 5 days of the cycle menstruating, because it is the best way to interpret the results. And after that, depending on the time of treatment chosen for each case, the most used are estradiol in the follicular, in the mid-follicular phase during the treatment, that should be between 150 to 180 picograms per follicle, not per milliliter, but per follicle. So you should perform the ultrasound first. LH to determine if the peak of ovulation are triggered and the ovulation occurred when the follicles has between 18 to 20 millimeters, and progesterone to determine the behavior during the luteal phase, more than 14 nanograms at the 7 days after the triggering of the ovulation, because it can vary from one patient to another. Almost all the books tell you the day 20 or the day 23, you have to check when is the ovulation and count 7 days after, and then you can make the measures of progesterone.
Okay. So in your experience, how fast do you need to receive this critical laboratory testing report in your office for your patient's convenience in terms of their treatment?
Okay, in our laboratory, for example, we have results report within 1 to 3 hours. And
Oh,
it's
wow.
very important because here in Colombia, we have a lot of traffic. I don't know if you have been here, but the traffic and the people sometimes live very far away that cost 1 to 2 hours to come here. So when she comes, we try to make everything she needs to help the patient to the convenience of the patient. And
Right.
the idea is resolving the patient case and avoiding a lot of visits.
Right. Yeah, that totally makes sense. I live in Los Angeles, so I totally
Yeah.
understand how that goes. All right. So how important is assay sensitivity when testing low hormone concentrations in early follicular phase samples? Sorry for mispronouncing that.
This is absolutely important. I showed the slide because it's critical to conduct and follow the treatment, because the treatment is going to depend if you have an ovulatory woman, if you have an anovulatory woman, you are going to make different kind of treatments. So you need to, of course, to know. And if you don't trust your laboratory, you are going to be in a very big trouble, because you can
Right.
make the wrong things.
Right. And do you find patients more engaged when hormone testing is included in fertility planning?
I think it's my experience, and I found that if you don't teach the patient in the appointment, and you don't say, okay, this is your case, you need that, you need this, we are going to make this test because we need to explain the reasons that explain certain tastes to the patient. And if she has to be breakfast, she has to be with any indication according to that indications that you as a doctor can give to the patient is going to be very correspondent to you. If the patient doesn't understand anything, she just go away and say, this doctor didn't make
Right.
me anything. I think you have to dedicate the time to explain the test and to explain the route that you are going to follow.
Right. Okay. Well, unfortunately, that's all the time we have today. So I'd like to thank today's presenter, Dr. Giuliana Puccini, and of course, Toso Bioscience Inc. for sponsoring today's event. We will send all audience questions received during today's event to the Toso Bioscience team, and they or Dr. Puccini will answer those directly. Now, if you have any additional questions,
Thank you
please
very
send
much.
them to me, webcasts@medcore.com, and I will forward those along and be very happy to do so. Also, please email me at webcasts@medcore.com. That's MEDQOR.com with comments, questions, future webinar suggestions. We're always looking for good ideas for future webinars. Also visit us at clpmag.com and follow us on all the major social media platforms. And thank you again for taking the time to attend this CLP webinar.
Okay, thank you. Bye.